please introduce the webinar?
Good afternoon, everybody. I am pleased and honored to invite you to attend this second webinar. I am Luis Mir, President of the ISC BTT, and I will co-chair this webinar with Professor Rafael Davalos, a professor at Virginia Tech. We are very glad to see you here. I would like also to thank excuse me 1 second. So I would like to thank, where is my file? I'm sorry for this delay. Something wrong appears here. I don't, well, okay, I wanted just to thank the both the council and the webinar organizing committee that was led by Julie Gill and constituted by Richard Heller, Javier Raso, Rafael Davalos, Giovanna Ferrari, Eugene Boroviev, Giampiero Pataro, Nabil Gremi, Ignacio Alvarez, and myself, who raised this interesting program. The program of today is devoted to oncology with 4 lectures. The first one by Richard Heller and will be introduced by my co-chair, Rafael. And I have a couple of announcements. The first one is please use the chat to raise your question to the lecturers. Thank you very much in advance. And the second is that Dr. Phoebe Lyons from the Cork University Hospital has made a pre-recording of Dr. Clover's presentation. Nevertheless, Jim Clover will join us for the question and answers after the presentation of the Dr. Lyons. And after having saying that, I just pass the floor to Rafael to introduce the first lecturer. Thank you very much.
Thank you, Luis. And there's one more announcement, a quick one, is that we will have the General Assembly meeting will be a different Zoom link that will enable everyone to participate and speak. So our first speaker is Dr. Richard Heller. His talk is on effective stimulation of an anti-tumor immune response utilizing gene electrotransfer.
Okay, thank you, Raphael, and greetings to everybody from all over. It's nice to virtually see everybody. So as Raphael stated, I'm going to give a presentation about some of the work that we're doing, looking at how to use gene transfer, and in particular gene electrotransfer, to change the tumor microenvironment in a way that makes it more conducive to immunotherapy. So there are several different ways that this can be done, if to be able to do gene electrotransfer or GET to stimulate an immune response. So in particular, focusing on cancer. And you could do this by delivering to a variety of different tissues, in particular muscle, tumor, and skin. We focus quite a bit on delivery directly to the tumor, which we think is really the best target, if you can possibly do it, for stimulating the immune response, as you are putting the stimulation exactly where it should be, where the tumor antigens are. And so you can get the appropriate response by doing that. There are a variety of different ways that you could do it. The plasmids can encode several different types of molecules. We've focused a lot on delivering plasmids encoding cytokines. This can be done as single agent or in combination. There are many people that are looking at doing combinations with ECT, and we may hear some of that later this morning or today. You could also combine it with other ablative approaches, such as radiation therapy or even IRE, which I did not put down here, but I believe that it could be done with IRE as well. You could also combine this with other immune modifiers, particularly checkpoint inhibitors, or it can be an adjuvant with surgery, where you can again remove the bulk of the tumor and then use the immune response to get rid of the rest, and also to potentially get distant disease. An important aspect of this is how you deliver that plasmid. And that's where the electroporation parameters come in to play on that. So by manipulating those parameters, you can get the appropriate expression pattern. For today, what I'm really going to talk to you about is how to use this in combination with checkpoint inhibitors. So just as a little bit of an introduction to checkpoint inhibitors, I'm sure most people know this has been the big breakthrough that has brought immunotherapy back into cancer therapy. There's been a lot of success with it, but there's also been some issues as well. And a lot of this, with respect to whether a checkpoint inhibitor is going to be effective or not, really has to do with the tumor microenvironment, and how it is. And there are different ways to categorize it. In a cold tumor is probably the one where there's the least potential for a response with a checkpoint. And in this case, it's for a couple of reasons. One is that there's no immune cell infiltrate, so there's not something that can stimulate to get that response. And then also expression of the actual checkpoint is very low. So if you have an antibody against that checkpoint and there isn't a checkpoint, you're not going to get much of a response. The second lowest is where you have an altered or excluded tumor, meaning that there are lymphocytes, but they're on the periphery of the tumor and not infiltrating. It really needed to be infiltrating inside the tumor to really be effective. And then also, the next level is immunosuppressed. So in this case, you have a suppressed environment. There are a lot of suppressor cells, a lot of markers that are really going to damp down the immune response. And then finally, what you're really trying to get is to have a hot tumor. In this case, you have very good infiltrate. You don't have a suppressive environment. You do have the potential for having checkpoints being expressed. And so it brings everything together where the checkpoint inhibitors can work really well. Over the last many years, there's a lot of work being done to try and figure out how to get these cold tumors or altered tumors to become hot. And there are a lot of different ways to do it. So, for example, if there's absence of tumor antigens or the appropriate stimuli, there are ways that you would attack the tumor either with drugs or with NK cells, which can kill the tumor cells. And they do this without having to have specific antigens present. Or you could use ablative approaches, radiotherapy, ECT, IRE, nanopulses. All these disrupt the tumor environment, can get antigen release, and can stimulate some sort of a response. With respect to absence of T-cell activation, there are also a lot of different ways that this can be done. Again, some of it is related to, again, disrupting the environment, doing some sort of ablative approach, or using some vaccine of specific antigens, or something that could stimulate a T-cell or an adaptive response. And then finally, when you get to impaired trafficking and infiltration of lymphocytes, there are several approaches here as well. So some of them include some antigenic approaches, TGF-beta blocking antibodies, cytokines, and then, of course, a GET as well to deliver any of these factors where you could put it in and have better control over the levels and the kinetics of it. So we have focused on using interleukin-12, and interleukin-12 is a very potent pro-inflammatory cytokine. It works extremely well to activate T cells as well as NK cells. And one of the problems that has been with IL-12 is that because it's such a potent stimulator, there's also some toxicity related to it. And this is typically when it's given systemically over time. So we have looked at over many years, and I'm sure people have heard me talk about this before, but we've looked at putting IL-12 in an intratumoral way using GET and being able to balance out the expression to either minimize or eliminate those side effects, but actually get that immune response that we're looking for. So I'm going to go through some of the things that we've looked at either as a single agent and then combining it with checkpoints. So initial experiments basically are using a B16F10 model in a C57 Black 6 mouse. We grow the tumors, and then at various time points, we look for analysis to figure out what's going on with the immune response. So at day 9, we will take tumors out, look to see if anything has changed in the microenvironment. And then later on, after we challenge, where we're hoping that we've stimulated a long-term memory response, about 20 or 30 days later, we would look to see what's going on in the periphery to determine whether or not we were able to sustain a memory response. So this is one thing that really actually shows how well IL-12 will work. So in this case, we're looking at effector cells within the tumor microenvironment. This is just really just representative, just to give you an idea of what's going on. You can see on the left panel that no treatment, very little infiltrate. So really this would be categorized as a cold tumor. But after delivering IL-12 with GET, you could see the influx of CD3s, T cells, quite a few T cells, but also quite a bit of CD8 positive effector cells. And this is what you want to see. This would be categorized as a hot tumor. So just to give you an idea, we've looked at this quite extensively, and this has been published. I would just go in very briefly, but just to see, we did a couple of different GET parameters just to see what was going on. It was very interesting. When we look compared to just injecting the plasmid alone or just pulsing or no treatment, you can see that we get a much better influx of lymphocytes or T cells into the microenvironment. These are CD4 and CD8s predominantly, and you can see in the breakup here, when you look at the two GET parameters, we're looking at mainly CD4 and CD8 cells. So the other thing is can you modify it to be a non-suppressive environment? So this is another example looking at the histology within, again, day 9 after the 3 treatments with GET. And you can see no treatment or just injection of plasmid. There's 2 aspects here. One is that we have a low level of infiltrate, a little bit better when we just do the IL-12 plasmid. But again, you could see levels of PD-1 and as well as FOXP3 showing that there are regulatory cells there, which are suppressing the environment. When we look at delivering the with GET, what we see is, particularly with the EP1, we could see very few, if any, regulatory cells. We see a few here. We also see a little bit of expression of PD-1 here, and not much, if any, with EP1. So EP1 is microsecond pulses, EP2 is millisecond pulses, is the primary difference between them. And this expression of the checkpoint inhibitors comes into play later on with this approach. So the other thing is to look at, again, summarizing the histology. And again, we could see that if we look at Tregs, when we deliver what we get, we could see a decrease in the Tregs. We see a decrease in PD-1, especially with the microsecond pulses, EP1. And when this is top is with CD4. And then if we look at the ratio of effector cells, CD8s, that are not expressing PD-1 versus regulatory cells, we could see the biggest increase again is with IL-12 EP1, but IL-12 EP2 is still significantly better than our controls. And this is also true when we look at the decrease in the levels of PD-1 within that microenvironment. So when we had done all of this, we also wanted to look at what was happening long-term to set up how are we going to approach this and move forward. So we knew now that we could modify the microenvironment, that we could set up them into a hot tumor, set up to have a good, robust immune response. But the question was, would that be sustained? Could we see that? And interestingly enough, when we look at these different aspects, when we look at them long-term, these mice long-term, their primary tumors go away and we re-challenge them. We do get a pretty good protection rate, but there are those that are not protected. So the secondary tumor, when we re-inject them, we do see some growth in some of the mice. And the question was, why is that? Why is it failing in some? And it's actually a very interesting dichotomy between the two. When we look at the ones that completely responded to the challenge and those that did not, you could see that there's a big difference. So in these, for example, PD-1 is elevated. Tregs are elevated. So it's not the environment that we want. We see suppressor cells are there. But in the ones that we have, excuse me, complete response, we could see that all of these are reduced. And so it makes sense that we get a response. And this is true both in the periphery and in the peripheral blood mononuclear cells, as well as in the splenocytes. And so this kind of tells us that we have to find a way to get this profile more than this profile. So it's actually a clear dichotomy when we see that. So with this in mind, we decided to go ahead and see how we could do this in a metastatic model, and then look at this in combination with anti-PD-1 and see if we could do it. And in this case, because we saw this spike in PD-1 expression on our T cells, we looked at using the millisecond approach so that we would have a target for our anti-PD-1. And the way we did this was we did our normal subcutaneous injection of our B16F10 cells, but then we took these stably expressing B16s with luciferase, and on day 0, the day of the first treatment, we injected them intraperitoneally, 5 times 10 to the 4th cells, and then treated again. And we had 4 treatments of the antibody and 3 treatments of GET. So these were followed. What we did was we imaged these mice a couple of times a week to look and see what was going on in the peritoneum, and then of course measured the subcu tumor. We also took samples to see what was going on as well. So in this case, it actually is very interesting. So, and there's 2 distinct responses. So of course we have 2 different sites where tumors are grown. We have it on the subcutaneously on the surface, and then we have the ones grown in a peritoneum. So obviously we can do direct treatment of the subcu one. And then with the IP, we're hoping that we've stimulated some sort of immune response that would get rid of them. So with the sub-Q, the only times that we actually saw the sub-Q go away is when we actually treated it with IL-12 get, where we would get a complete response. There was a little bit of a response when we did just the injection of the plasmid plus the anti-PD-1, but it was not sustained and was only in a single mouse. And then, interestingly enough, when we look at the response in the peritoneum, when we did the combination, the IL-12 get with anti-PD-1, we could actually see a really good response, 90% response in long-term in those mice. We did see some response, which was interesting, with just the IL-12 get, that both in the sub-Q as well as in the peritoneum, which was actually very interesting. We didn't think it would be that strong, but it was pretty good. And then the anti-PD-1 with IL-12, we did again have 1 or 2 mice that did respond to that. We're looking at here is just different time points of looking at the imaging of up to 5 mice. We did this a couple of times with 5 mice each time. You can see with no treatment, day 1, this is a day after the initial injection into the peritoneum. You can see already there are tumors forming. This just continues to grow. These mice did not survive much after day 10. Whereas when we did the combination, you could see that already at day 1, you could see tumors forming, but as we follow them long-term, even out to day 100, you could see that these mice are tumor-free. And it's actually very nice. You actually even see on some of them some vitiligo forming, showing some signs of the immune response. So what was actually going on? We kind of looked at this a little bit closer to try and see is there any way to improve it or to figure out why are we seeing this. So first we were looking at where we're getting the IL-12. We looked at both within the tumor homogenate as well as in the plasma, and we could certainly see it in the tumor homogenate because that's obviously where we delivered it. We did see it a little bit of a spike in the plasma, which was a little bit surprising because we had not seen that before. And then for interferon gamma was the same thing. We could see it show up in the homogenate and also in the plasma. And of course, gamma will mirror 12. So as 12 goes up, gamma will be a little bit delayed, but will also go up. The other thing we did was, again, look at the tumor microenvironment to see whether we are still seeing similar aspects in this. And you can see the same thing if we did IL-12 get or IL-12 get with the anti-PD-1. Again, we could see the tumor going from cold, as you can see here in a no treatment, to a hot tumor. And this is quantitated below, as you can see, for CD4 and CD8 is clearly a significant increase in both CD4 and CD8. Interestingly enough, and actually beneficially enough, predominantly this was CD8 effector cells. So the other thing, again, looking at regulatory aspects, suppressor aspects, whether or not we have PD-1 expression or regulatory cells with FOXP3 expression. And looking at this, you could see that when we look at IL-12 get or with anti-PD-1, we could see mostly CD8 cells. You can see really a high level of CD8 cells as opposed to the controls. We don't really see that. With IL-12 get alone, we're also seeing some expression of PD-1, which was not a surprise because we saw that in the monotherapy as well as some regulatory cells showing up, which we don't see in the combination, which was also a very interesting thing to find. So the other thing we wanted to do, because we were kind of getting this notion from evaluating the microenvironment, that the response is linked predominantly to CD8 cells. So we went ahead and did deletion experiments where we tried to get rid of CD8, CD4, NK cells, as well as interferon, and see what it did to the response. And essentially, you look at this, we can see that CD8 really was predominantly the cell that we needed. If we get rid of CD8 cells, you can see that we get this continued tumor growth. There's really no effect of eliminating the NK cells. CD4, we did see an effect, not quite as much as CD8, but it does show that CD4s may still be necessary within there. And of course, the need for gamma interferon. And you can see that when we eliminate gamma, again, we could see that the response is eliminated as well. So then we wanted to look at the long term, as we looked at before. So even though we had done this as a metastatic, even for those mice that were tumor-free, both in the peritoneum and also sub-Q, we then challenged them again to see what was going on. And this is, you can see with our naive controls, they all got tumors. And we still had protection with actually both our IL-12 get and the combination one. And so this is kind of interesting as well. And within this, what we wanted to look at was what was going on as far as our memory cells over time. So looking at this now out to 125 days, and you could see that both central memory and effector memory are elevated, both in the short term. You could see, so initially when the original tumor is still there, and we have the metastatic spread, and then we see it waning a little bit, and then a challenge happens right around here, and again we see another spike of the memory cells, both with IL-12 get by itself and also the combination. So it kind of shows this, that we can see this really nice effect when we deliver in this way. We also we're looking at this again, and this is in a peripheral blood, and it's similar pattern, although in this case, in the periphery, we're seeing more central memory. If we're looking here, we're looking at it's not much difference between the central and effector memory, as we see here. And then finally, we look at here, we're again looking at what's going on as far as memory. And in this case, again, this is again in the peripheral blood, but again, looking more now at Tregs and DSCs. So we could see again, increased memory, this case central memory, this case both central and effector. And now, oops, sorry, when we look at in the contrary to it, whether or not we're seeing the presence of suppressor cells, interestingly enough, we are seeing MDSCs early on, but they're waning. And so again, the challenge happens around here, and we're not seeing them elevate up. So we're still suppressing those, blocking the suppressors. And this allows us to get that effect, to be able to block that growth of the re-challenge, the new tumor cells that are being injected. Then finally, what we wanted to do, because we saw that interferon was playing a role, we were curious to see how it played into this. So looking at another checkpoint marker, PD-L1, and also MHC class 1 expression, both sort of play a role in seeing that response, and looking to see whether no treatment or with pulse or delivery IL-12, and then increasing levels of interferon. Interestingly enough, that when we're looking at this, so for example, here we are looking at expression of class 1, you could see straight down on A, B, and C. With different with the different treatments. It's interesting that right away, even without the interferon, we're seeing with IL-12, we're seeing this increase of class 1 as well as PD-L1 with this. Although with PD-L1, clearly these P16s are expressing them even without interferon. So these are, and that's not unusual for these PD-L1 cells. And in any event, the summary of these guys with these, you can see here at 24 hours, again, for class 1 and PD-L1. So, sorry. And the summary is just for 24 hours, but you can see it's very similar to 48 to 72. It's interesting, though, that class 1 at 72 hours is not quite as responsive to the interferon, but it does show the role of interferon. And when we did the depletion experiments, we did see that interferon had a role in this. So basically, what we're coming to a conclusion that in a monotherapy, that the level of the cytokine expression really is critical to regression and get that memory response. And then when we do the combination, we also need to think about how the expression is. And then if we're using a checkpoint, we need to look at how that delivery is affecting the expression of checkpoints, depending upon which one we might use. So for example, here we're seeing quite an elevation of PD-L1. So we're going to look and see about using anti-PD-L1 as well and see what's going on, which could help also in that metastatic model, because we know that the B16s are expressing PD-L1 even at the beginning, as you can see here, that they have a baseline expression of PD-L1. So in summary, we believe that we have the evidence that shows that delivery of IL-12 with GET definitely changes the microenvironment. It moves it towards a hot scenario. The treatment of IL-12 GET with anti-PD-1 enriched T cells both in the peritumoral areas, within the tumors, and also decreased exhausted effector cells. We saw more memory cells in the circulation, which helped with metastases and, of course, with the memory response. The combination yield high ratios of effector cells not expressing PD-1, which kept them active. We also saw a major influx of the CD8 cells into the tumor microenvironment. And this, of course, was associated with seeing the regression of the tumor and also long-term tumor-free mice, and as well as being able to resist challenge with new tumor cells. So just want to acknowledge people that did the work at USF. This majority of the work was done by Guilan. Jody helped, Marie was there for her help, and Mark helped with a lot of the different GET equipment. We started to work while we were still at ODU, and Catherine, Chelsea, Megan, Shauna did a lot of the original IL-12 work, and then Ellen helped a lot with the flow cytometry. And then, of course, want to thank our support. And I thank everybody who's attending, and I hope to see everybody next year in Copenhagen. Thank you.
Great presentation. Richard, I don't know if you can see the Q&A in the section.
Yeah, I'm looking now. Question from Dom Yan mentioned that you can achieve different expression profile by using different pulse parameters. I remember this for skin. I think it has to do which cells are being transfected. Is different expression profile observed in muscle transfection? Okay, good question. All I could do is give you what I think. We haven't actually tested it in muscle. We've mostly focused in other tissues, but I believe that would be true. And we did very early on when we weren't necessarily looking at this closely. We had done microseconds versus milliseconds in the muscle, and we did see some expression with microseconds. It was much lower than with milliseconds, but we didn't really look at it close enough to come up with a definitive answer to that. How close are we? This is from Borkos. How close are we to serious attempts at getting this kind of GET treatment through process for FDA approval? Saying this as an example. Okay. Yeah, good question. So I didn't mention that in my talk, but there are clinical trials going on right now using IL-12 GET with EP1, the microsecond pulses, combined with anti-PD-1. And this is working out really well. The initial phase 2, they had over a 50% response rate for complete response rate, meaning treated and untreated tumors going away. They went to the FDA, and they're now, if I understand correctly, they're in a regulatory trial, and the FDA is requiring them now that the patients enrolled are patients that have failed checkpoint inhibitor therapy. So these are people that were refractory to checkpoint inhibitor therapy. So obviously it's a much higher bar that they have to go through. The last I heard, they were still seeing responses, not at the same level. I think it was more in the maybe 15 to 20% complete. And then partials were somewhere in the 30 to 40%, which is still pretty good. And I think they're going back into discussions with the FDA now to go into a final trial that would lead to approval. This is from Bogdan. Have been any flow cytometry observations on tumor-associated monocytes of evolution during the experiment? Yes, excellent question. We've not really looked at that, but that would be the next thing to do. So we've kind of focused on the T cells because that's what we were trying to stimulate. So we were looking at that, but that is something that we will start to look at because yes, I agree that we need APCs there within that environment to be able to get the correct presentation of the antigens that are being released. If I had a guess, I would say that we're seeing that happen because of the responses that we're seeing, that I believe that we would have to have APCs there in order to see that, as well as seeing the levels of gamma interferon that we're seeing. I think that was the last one that I see. Raphael, am I missing anything? Did I miss something?
No, I think that's good. I think well, thanks again, Richard. Thank you very much.
Okay, so thank you very much, Richard, and to keep the schedule and not to be late more, I will immediately introduce Dr. Luca Campana, working on ECT since many, many years. Now on a talk on electrochemotherapy and immunotherapy in malignant melanoma, which I believe it's really a promising alliance. And please, Luca, the floor is yours.
Thank you. Good afternoon, everybody. It is a pleasure to be here waiting for the Congress in Copenhagen next year. I will try to give you some good news regarding the combination of electrochemotherapy and immunotherapy, starting from the clinical side. So, as you are well aware, there are tons of literature out. There have been massive improvement regarding the treatment of systemic melanoma following the introduction of new immunotherapy agents and targeted therapy. Still, a number not negligible of patients does not benefit from these agents, and particularly those patients with skin metastases experience a dramatic impact on their quality of life. So, as long-term electrochemotherapy users, we are now convinced of the efficacy of local treatment with electrochemotherapy. But we are also aware of this collateral mechanism of actions of electrochemotherapy, as highlighted in this paper by the group of Prof. Mir. Basically, we have an immune effect, namely the release of some sort of danger signals from cancer cells treated with immunotherapy, with electrochemotherapy, sorry. And this mechanism can be further highlighted by the combination of ECT with the novel immunotherapy. So our background and our awareness is that nowadays ECT is more than a mere cytotoxic treatment, and ECT induces the hallmarks of immune cell death. So in a sense, it may predispose the tumor to the recognition, to the effective recognition by the immune system. So basically, the underlying hypothesis also presented in detail in the previous talk is whether a cold, uninflamed tumor can be turned into a hot tumor. Having an effective local therapy in ECT, we try to combine one of the most commonly used immunotherapy agents with immunotherapy. And that's what we did. I'm going to present briefly this recently published paper, which is an effort by the INSPECT group. So I have to thank since now all the participants, because it was a nice collaborative effort by several centers. Basically, we joined the INSPECT registry with the Slovenian Cancer Registry, and we look for the outcome of melanoma patients who received both pembrolizumab and electrochemotherapy. So the study design is retrospective, registry-based, combining these two databases. The study population is composed by stage 3, stage 4 melanoma patients with visceral and superficial metastases amenable to electrochemotherapy. And we compared these three groups: patients who underwent ECT, patients who underwent pembrolizumab, and the patient who received the combination. Since now I want to clarify that the majority of patients in the combination group started with systemic immunotherapy and then received electrochemotherapy within the first 2 months from the start of pembrolizumab, just to give you an idea of the timing. Regarding the characteristics of these three groups, because of course being a retrospective trial, it is open to a lot of biases, so results can be taken, should be taken with granum salis, as we say in Italy. But just having a look to the characteristics of these three subgroups, you can notice that the pembrolizumab group is made mainly by patients who did not receive previous local therapies and who did not receive previous systemic therapy. So in this sense, the pembrolizumab group seems to be favored because more the treatment, we assume more the disease stage of the patient. So there is an a priori imbalance favoring the pembrolizumab group. The first result, which is a priority as a clinician, is that the combination is safe because still there could be an unfavorable interaction between these two treatments. But overall, we can say we did not detect any increase in both local and systemic toxicity, and the systemic toxicity profile is in line with previous major trials with pembrolizumab in humans. So we have no toxicity concerns from this study. Regarding local response, but I don't want to stress this data because local response is just one, and if not the less important outcome for this kind of patient, because melanoma, I want to stress this aspect, is a systemic disease compared to other type of skin cancer we are treating with electrochemotherapy, such as squamous cell carcinoma or basal cell carcinoma. This is a systemic disease. Anyway, you can appreciate that there is a dramatic improve in the rate of local response. In the pembrolizumab alone group, you have an overall response rate around 40%, and with the combination, we achieve a 77%. So this is good for patients and not quite unexpected for ECT users. What I want to stress instead are the next three slides, because first of all, we noticed an improve in the local progression-free survival. So in the number of patients who maintain the control on the electroporated tumor. So you can appreciate a nice separation between the two curves, between the pembrolizumab alone group and the combination group, the higher curve. So after 1 year of follow-up, 86% of the patients in the combination group were free from progression, compared to half patient in the pembrolizumab alone group. This is quite impressive as a difference. But what was even more surprising for us as clinician is that we observed a difference also in the rate of progression on distant metastases. So those metastases that were not treated with the local treatment. So after 1 year, you can see a nice divergence of the two curves with 64 versus 39%. Finally, so I mean, for the instant metastases, we include the patient with lung metastases, liver metastases, brain metastases, and so on. Finally, which is in a way the cherry on the top of this analysis, we also confirmed a benefit in the combination group regarding the overall survival. So after 1 year, we have a rate of rather 90% versus 64%. So from a clinical point of view, these are really great news because are dramatically improving the outcome of patients. So if we may summarize, I would say that in the combination group, where the patient have a fourfold higher chance to maintain their control on the superficial metastasis. They have 1.7 higher chances to not progress on systemic disease, so on the lung, on the liver, but most of all, they have rather their chances of overall survival doubled in the combination group. So this is quite amazing results. If we are going to translate these results as a message for the clinician, we could say that the surgical oncologist, who are usually the user of local therapy, should be aware of the necessity to refer this patient to the medical oncologist if they want to improve on the long term the outcome of a melanoma patient treated by electrochemotherapy. On the other side, the medical oncologist should be aware that if these results will be confirmed by associating their powerful immunotherapy agent with a local therapy, in this case electrochemotherapy, they have the chance not only to prolong the control on the disease, but also to extend patient survival, which is a striking concept for the medical oncologist. Just this slide is just to convince further the electrochemotherapy users that nowadays melanoma patients are living longer. Each one of these curves represents a new agent which has been recently introduced in the treatment of metastatic melanoma. And you can see that the curve, the Kaplan-Meier curve, is becoming higher and higher. So the outcome for this patient is not achieving the response on the single tumor, on the single metastasis, but extending their survival. So next, we were wondering if improving the outcome of this patient in this specific study, we have activated in a way the immune system of this patient. Of course, this is a clinical study. There were no biological correlation, but I want just to make you aware that we have recently proposed a roadmap with Prof. Sersa and Prof. Heller on how to boost the research on the biological factors connected to response or benefit to electrochemotherapy. And in this paper, we propose a frame, a setting on how to dissect in details or all these aspects, mainly related to the biological characteristics of the tumor itself, but also to the tumor microenvironment. So I think this could be the best appetizer for the next year Congress, because much remain to be done, basically linking all the biological aspects with a focus on the cell infiltration of the tumor microenvironment with the results coming from the clinic, because both seems to be highly exciting. Now we have to look and link these two sides. So the conclusions for this talk are with the new immunotherapy, melanoma patients are living longer. So the relevant outcomes are not only tumor response, but the disease-free survival and overall survival. Electrochemotherapy is more than its cytotoxic effect. So let's keep in mind the paper by Prof. Mir on immunogenic cell death. The combination of pembrolizumab and ACT was beneficial in this retrospective study in terms of all the relevant oncological outcomes, including patient survival. These results, of course, need to be confirmed prospectively because this kind of studies are open to many bias, and which is exciting for me. There is a need for mechanistic investigation, so we hope to go through this roadmap on biological factors related to benefit from immunotherapy. Thank you for your attention, and I hope this is a good appetizer for next year.
Okay, thank you very much, Luca, for this presentation. I see that there is one question from Damian Miklaucic. Thank you, very impressive. Since the study is retrospective, do you have prospective study in plan? Which was exactly the same question I had.
That's a fantastic question. Next Friday, we have the annual meeting of the INSPECT group. So I think we should discuss about this, most of all because we want to confirm this data, but also importantly, linking some translational study. This could be really the top for the prosecution of this research.
So anyway, we are waiting for more results and more discussions in the next World Congress in 1 year from now, as you said. So thank you very much. Sorry, there is still one more question. No, it's just a comment from Damian saying.
Okay, thank you.
Okay, all right, thank you, Damian. And so thank you, Luca. We are going to move to the next presentation because we are running late. And this is a presentation that has been recorded by Philly Lyons, Dr. Philly Lyons, a colleague from Dr. Jim Clover. Dr. Clover will be present at the time of the question and answers. So he will be able to answer to your questions lively. By the way, sorry, Luca, there is also in the chat a comment from Dr. Rasmus Flack. Dear Luca, thank you. Do you have any comments about the timing of ECT and checkpoint inhibition? Maybe if you can answer in 30 seconds maximum.
Yeah, basically this is open to investigation. The majority of patients were started with immunotherapy and then get local treatment. This is a fantastic question. No data available by now, but many hypotheses. Happy to discuss when we have more time, even by email if you want. Thank you.
Thank you very much, Luca. So now next presentation is on high frequency electroporation and chemotherapy for the treatment of cutaneous malignancies, evaluation of early clinical utility and response. So if we can move to the recorded presentation, thank you very much. We have a problem of the sound.
You've heard previously about the effectiveness of targeted ECT for disease control. This is an update or modification that allows treatment to be delivered under local anesthetic. This schematic shows that by applying an electric current to cells, the membrane becomes transiently permeable, allowing treatments to cross the cell membrane. High frequency electroporation differs from traditional ECT by using high frequency bipolar waves, but the net result is the same. ECT is a well-established treatment of both primary and secondary cutaneous malignancies, as was shown by a large multi-center European-wide prospective study published in 2020 by Clover et al. There is, however, a specific window for reversible electroporation, which is controlled by electric field strength and pulse duration. Too much can lead to either irreversible poration or thermal damage to the skin, while too little will not cause any poration. A preclinical study was carried out in a small animal model that demonstrated that the high frequency protocol was as effective as the standard protocol in tumor control, which is shown in this graph with the black line as no treatment and the other groups closely aligned with excellent control at day 20. In our study, 20 patients were enrolled, with 16 patients completing follow-up from July 2019 to March 2021. Patients received either local or general anesthesia, with one patient receiving spinal anesthetic, which is an increase in local anesthetics from previous studies. Bleomycin was either administered intratumorally or intravenously, with the average age of the patients being 74 years. Patients were then followed up at 4, 8, 12, and 21 weeks, up to 73 weeks post-treatment. This video shows the treatment delivery under local anesthetic, which is quick, efficient, and well tolerated by patients, as you can see. Multiple cutaneous malignancies were treated, with the highest being melanoma, followed by BCCs. The left table represents lesions treated, and the right table, the lesions analysed. The number of lesions analysed was limited to 7 per patient, as per oncology trial reporting, in order to reduce reporting bias. The high frequency electroporation was objectively successful in all but one case, where excessive moisture at the tumour site was an issue due to reduced impedance, and there was no immediate intra or post-procedural issues. The graph represents the response per lesion, where dark blue represents complete response, orange is partial response, yellow is disease progression, and grey is unable to assess. This shows that the levels of complete response increased and stabilized as the patients completed follow-up, with 62 of 77 lesions having complete response at 73 weeks, which is an 80% complete response rate. Additionally, from follow-up 4 to follow-up 5, only 4 lesions with a previous partial response underwent disease progression. From the overall patient response point of view, there was an overall response of 85% at 12 weeks and a complete response at 66%. Then in comparison, a European-wide study published in 2020 by Clover et al., which looked at electrochemotherapy across various cutaneous malignancies. In comparison, our data demonstrates equivalence of high-frequency electroporation with traditional ECT, with an 80% total complete response in comparison to their 71%. This is a clinical example of one of the patients enrolled in our studies preoperatively with multiple BCCs. In total, there were 11 lesions analysed, with 9 undergoing complete response and 2 a partial response at 3 months follow-up. In summary, high-frequency electroporation is well tolerated by patients under local anaesthetic, and our results show it's efficacious with responses across multiple primary and secondary cutaneous malignancies. Our data therefore suggests overall equivalence between this and traditional ECT. Thank you for your time.
Okay, thank you very much. So Jim Clover has joined us. Thank you very much.
Thank you.
There is already a question from Damian Miklaucic. Thank you. Can you specify HF-EP parameters? Because That is pulse duration, interpulse, interface pose, number of pulses in a train, etc.
I would need to refresh myself about the exactness of where it's short bipolar and short bipolar waves, and I actually don't, sorry, I just don't have that to hand just at the moment, but if I can come back to that if you like in just a minute, I'd need to remind myself of the exact parameters, but it's a shorter bipolar wave of 200 microhertz, if I remember off the top of my head. But can I clarify that with you, and I could always get back to you.
Okay, thank you very much. By the time being, there are no other questions but I have one at least is which device did you use to deliver the pulses? First, in terms of the generator, and second, also in terms of the electrodes, were the same electrodes or not?
So this was using a device that's relatively new to the market with its CE mark by Mirai Medical. And so the generator is specific to Mirai Medical for the high frequency bipolar pulses. And they have a cutaneous probe called Cutis that was used for the delivery of this. So both the probe and the generator was used for this delivery.
So the cutaneous probe was different of the classical electrodes used in electrochemotherapy?
Different from the IGEA probe. Still a parallel array pattern with 8 needles. So very similar, but a slightly different design. But I mean, really, the point of this is that there are newer, also we're starting to question whether or not we can exploit the electroporation window, and I believe it's really important that we assess it against the known means. And whilst this study is limited by its its small numbers and relatively short follow-up, it is at least giving us early indications that it's possible to potentially widen some of the pulse parameters beyond the ESOPI guidance. But I would have a caution that we need to do this in a controlled way and making sure that we're evaluating it against what we know works as we progress.
Okay, thank you. There is now another question, a couple of questions. The first one, very interesting. Do you see any kind of muscle contraction or sensation referred by the patient?
What's unusual is that you can you get very little muscle contraction. As we know, it depends how close you are to either a nerve or to a nerve to see whether you can stimulate it. You get there is a little twitching, sort of similar to the bipolar frequency. So you can get a little bit of muscle twitching, but actually far less muscle twitching. And it's, in my own personal experience, this is better tolerated than the conventional pulses because, it's high frequency twitching and appears to be less painful and better tolerated by the patients.
And how long is the overall duration of the treatment?
So each pulse
For
can
one
be
position.
One position. I mean, it's a 200 microsecond pulse, so
Okay.
it's relatively quick to put in and to move around. And there's also I need to open up my computer, I'm afraid, to answer specifically the length and the number of pulses.
Yes.
It's as I said, it's bipolar. It's bipolar pulses, and I can just get back to you on that if that's okay.
Yeah, maybe the persons interested can send an email request by email to you and to get this.
Absolutely, and I must apologize again for not having that to hand. That's
because this question of Matias Tellado joins the question of Damian Miklaucic at the beginning of the discussion. And so I have also another question in the chat from Richard Heller. How was the healing, particularly the lesions on the face?
So the lesions, I didn't notice that the lesions on the face healed quite well. I mean, I think if you look at the some of this early data, there was probably a little bit more of a marked tissue reaction compared to using the standard electrochemotherapy machine. I think that there might, this is an anecdotal thing, but if you have a look back, we had a slightly higher percentage that were unable to assess at the 4-week window than I might have expected using using an IGEA device. This sample is too small to see whether that's any significant in any way, shape, or form. A little bit slower is probably is my impression, but I'd need to evaluate that more formally for you.
Okay, thank you very much. I don't see now more questions. So thank you very much for answering to the questions, and thank you to your colleague for presenting the data.
Thank you. And thank you for your interest in this early clinical outcome. We look forward to updating you next year. Thank you very much.
All right, yes, we will see together next year in Copenhagen, and we
I
will
hope
have
so.
time to discuss in detail.
Thank you.
Thank you. Okay, and now I will move immediately to the next talk by Dr. Rasmus Flack from Denmark, which has the title is, Does imaging response after irreversible electroporation correlate with survival in localized pancreatic cancer? ? So thank you.
Thank you for letting me present amongst such honored speakers today. As you said, my name is Rasmus Wierenfeldt Flack, and I'm a PhD student at the Department of Gastrointestinal Surgery in Aalborg University Hospital in Denmark. And as a part of my PhD, I have examined how we measure imaging response after irreversible electroporation in pancreatic cancers. We've performed a cohort study, and as part of this, I will present a sub-study that we have performed. So it all started with a research question. Whoops. How do we actually measure the response after local interventions? The problem is that what we see in pancreatic cancer, what we visualize by CT scan or other morphological scans, is actually not the tumor itself. It is fibrosis. And when we perform a local procedure like IRE or radio frequency ablation or something else, we get even more scar tissue and even more fibrosis. And the tumor may shrink, or it may become larger. But how can we? So when we know that all of these processes are going on, how can we measure if what we are doing is effective? And there are basically two different schools of thought, and I will show you that the literature on this is very, very divergent. Yeah, so the normal go-to when we measure objective response in tumors is response evaluation in solid tumors version 1.1, which is the current version. And to those of you who don't know it in detail, what you do is that you pick up to 5 target lesions, and with a maximum of 2 per organ. And then to be a target, a lesion must be measurable, and what you do is you measure the diameter of the lesions, you summarize them, and then you see, and then you take the summarized diameter and look for changes across time. And if any new lesions appear, then you're automatically in the category of progressive disease. But otherwise, based on some percentage cutoffs, you have complete response, partial response, stable disease, or progressive disease. But the problem is that when we perform a local treatment on a tumor, this immediately makes the tumor fall into the category of unmeasurable disease. So we can't really use the standard RESIST criteria for measuring this. And of course, RESIST knows that some lesions are unmeasurable, so they have a solution for this. And that is that unmeasurable disease becomes something called non-target lesions. And non-target lesions can be categorized in 3 different categories: complete response, progressive disease, or non-progressive disease, basically. And to become progressive, you have to have an unequivocal progression of the existing lesion or developing of new lesions. So taking this concept, we can somewhat estimate whether something is progressing or non-progressing, but it's hard to estimate whether a partial response, for example, is accomplished. But the Society of Interventional Radiologists have come up with some solution for this. They have produced a consensus paper in 2014, and some of the key points in the context of pancreatic cancer is that they have a standardization of terminology, and one of these standardizations is that is something called technical efficacy. So technical efficacy is what you see if you apparently have no residual tumor tissue after an ablation and on subsequent imaging. And of course, this the subsequent categorization of lesions is very dependent on whether you have an efficacious have achieved technical efficacy or not. But the other recommendation that the SIR gives is that by using the first post-ablative imaging as the baseline for comparison, much of the issues surrounding the effects of ablation can be avoided, or and that because then you can basically use RESIST as you would normally do. So in order to examine this, we designed 2 different studies. The first is a systematic review of the current literature on ablative treatment in locally advanced pancreatic cancers. And the second is a retrospective analysis based on the findings that we found in the review. So both have been published, by the way. And the first study we found after a systematic literature search, we found 34 studies to be included. These are 34. It's a very busy slide, so don't pay attention because I'm going to explain it. What we found was that 33 studies used CT scans for measuring response, and 13 used MRI, ultrasound, or PET scans in conjunction. And 9 of the 13 used mixed modalities across time or across patients, and 1 used MRI only. 27 reported the comparison target, whether it be on the patient level, so also taking into account new metastasis forming, or on the lesion level, so only looking at the lesion. And 5 of the 27 reported both of those targets. 16 compared follow-up scans to pre-therapeutic scans, and 2 compared to the first post-therapeutic scan as recommended by the SIR. And in 16 of the studies, we could not determine which scan was used for comparison. And also 14 of the 34 used some form of standardized criteria. So for example, RESIST CHOI criteria or something else that is published in an international journal and recognized. And 6 did not report what method of evaluation they performed at all. 4 compared outcomes using different imaging modalities and/or response criteria, and 1 correlated imaging findings with survival. So there's basically only 1 study that has proven whether it is whether there is evidence for doing response evaluation after local ablations in pancreatic cancer. So our conclusions in study 1 was that the use of response evaluation differs widely in the published literature, with little evidence of correlation with survival. Further studies regarding the response evaluation after local ablation is warranted, and future authors should adapt common terminology and methodology, and should report key imaging parameters like timing, evaluation target, and comparison scan. So based on this, we designed our own study to see if these findings at all correlated with survival. And fortunately, we had already performed a prospective trial of pancreatic cancer patients, non-metastatic pancreatic cancer patients treated with irreversible leg furation at our hospital. And as part of that study, we had performed PET-CT scans. So we included 41 patients, and most of them had a locally advanced pancreatic cancer. There were 4 that had local recurrence, and 4 patients also had medically inoperable but otherwise resectable pancreatic cancer. FDG PET scans with contrast enhanced CT was performed at baseline every 3 months. And we censored scans after 6 months because some patients were treated more than once with IRE, and some patients were actually downstage to and had performed a resection, and a lot of patients received chemotherapy after this point. So what we found regarding the patient level response was that progressive disease, according to RECIST 1.1, was actually significantly correlated with mortality rate, which is unsurprising. But what we found was that it was clearly more or better at differentiating progressives from progressives when we used the first post-ablative scan for comparison. So, but our PET scan, we analyzed our PET scan using the EORCT criteria. Unfortunately, we could not use the more modern PERSIST criteria because we changed scanner during the study, and that destroyed our possibility of doing so. But we used the EORTC criteria, and using that, we found that there were no significant difference in the earliest scans of the baseline to 3 months. And but from baseline to 6 months, we did find a positive correlation. And from 3 to 6 months, we were not able to differentiate patients at all, because all of the patients had progressive disease according to EORTC. Of course, this could be true, but it's not really helpful. Going over to the local or lesion level analysis, we found that local progressive disease based on the RECIST cutoff value of 30%. We found that none of the time intervals produced significant results. And that was actually the same with all of our PET values, maximum standard uptake value, metabolic tumor volume, or total lesion glycolysis. However, metabolic tumor volume and total lesion glycolysis tended towards significance. So there's a probability that with a larger study, these would have become significant. So the conclusions from study 2 is that patient level progressive disease based on RECIST 1.1 correlated with poorer survival after IRE in non-metastatic pancreatic cancer. And FDG PET is likely confounded by inflammation in the early post-ablative period, and is not better than CT in differentiating progressives from non-progressives. Lesion level outcomes are inappropriate for evaluating efficacy at this point in time. So returning to our main research question, how do we measure response after local interventions? The simple answer is that we cannot measure whether patients has a response or not with the current methods that we have. However, there are some new radio tracers and also MRI techniques such as hyperpolarized MRIs, which are likely to solve this problem in the future. But what we can is that we have produced results that definitively show that the patient level progressive disease according to RESIST is it does correlate with survival. Thank you very much.
Okay, so thank you very much. I see that there is already one question from Dr. Siki Guo. What are the sensitivities of these imaging modalities? 10 to the 5 cancer cells?
I have no idea how many cancer cells are in a pixel or voxel. I'm sorry.
I may understand because you have the tumor environment, other cells invading.
Yeah. So these are patients, and they are the scans are performed in clinical CT and PET scanners, which typically would have a slice thickness of around 5 millimeters, 2.5 millimeters.
Yeah, it's more the volume that you can measure than the number of cells.
Yeah.
I don't. Yes, there is a comment or question from Dr. Luca Campana in the chat. I agree that PET-CT is not particularly helpful according to our experience with variable geometry ECT, long electrode needles in deep soft tissue tumors.
Oh, I'm sorry. My phone is ringing. I just have to turn it off. Just a second. Yes. Yeah, at least not with 18 FTG as the tracer. I've just read a review about some new novel radio tracers that are more specific to pancreatic cancer, and they would probably be helpful in this regard.
Okay, so if there is no other question, because we are running a little bit late, I will pass the word to my co-chair, Rafael Davalos, to conclude this webinar. Thank you to you for this complete presentation and to all the other presenters. Rafael?
Okay, thank you, Luis. Yes, again, thank you everyone for participating. Those are some incredible talks. This is just a reminder that we have our General Assembly meeting. It's actually going to start in about 1 minute, but it probably started in a couple minutes. But it's a different Zoom link. So for ISEBTT members, you should have that link, and we look forward to talking to you all then. Okay, thank you, everybody.